Hello again, this is Anil here at DiCarmel NCLEX review program. I hope you would have listened to my video on acyanotic versus cyanotic heart defects. It's a continuation of the same series. Here I'm going to talk more details on Tetralogy of Fallot, one of the most classic cyanotic heart defect which NCLEX repeatedly asks. So let's look into the classic features of Tetralogy of Fallot and its management in this lesson. As you might already recollect, Tetralogy of Fallot is a combination of 4 defects, as you can see right here. It includes pulmonary stenosis, right ventricular hypertrophy, overriding of aorta, and ventricular septal defect. And just a quick recollection, a comparison once more, what happened with the acyanotic? The blood from the left side can flow to the right side. But the blood that is getting pumped out from the left ventricle via the aorta, it is still oxygenated. There is no mixing of deoxygenated with the oxygenated blood which is getting pumped out. So that's why that doesn't cause cyanosis. But here in Tetralogy of Fallot, it typically causes cyanosis. And let's see how that happens once more. As it is listed here, these are the 4 component defects. They do have a large VSD, right? We know when there is large VSD, blood from the left ventricle can flow to the right ventricle. But that blood cannot escape into the lungs because of pulmonary stenosis, which is the second problem. And that is going to build up too much of pressure in the right ventricle. That's where they're going to end up with the right ventricular hypertrophy. And also, the last component defect in the list is overriding of aorta, which means aorta is positioned in the right and left ventricle. So as a result, what happened? So blood from the left ventricle goes to the right ventricle, but because of pulmonary stenosis, it cannot escape into the lungs. It's going to build up in the right ventricle. Because of the increasing pressure in the right ventricle, it's going to flow back to the left ventricle, and it causes a total mixing. It is a mix of blood which gets pumped out via the aorta, which can result in cyanosis, particularly of the peripheral tissue. So let's look into the classic findings with the Tetralogy of Fallot. The first one, polycythemia. This is another beautiful topic I always highlight in my lessons, and you would have possibly listened to that video already on polycythemia. And as you might be aware by this time, polycythemia is a compensatory mechanism. Whenever there is lack of oxygen for a prolonged period of time, that can result in compensatory overproduction of RBCs, and that's what we call as polycythemia. So the polycythemia that can increase in these children can naturally increase the blood concentration, the hematocrit, and that can increase the risk of stroke, which is one of the complications of Tetralogy of Fallot. Another classic problem these children can present with, they can present with the clubbing of fingers. And as you can see here in this image, you can see what is clubbing. Like there is a change in the angle of the nail bed. As you can see, the normal nail bed angle is around 160 degree, and here it increases to almost 180 degree or more with the drumstick up or the spoon shaped appearance, as you may have heard. And also, to talk a little bit more about clubbing, you can see here on the next image, which is another repeatedly asked question. A classic sign of clubbing is absence of Chambrot window. You can see what Chambrot window is. Like if you hold your fingers together, and you can look right here in the image I'm showing you. What happened? You can see a narrow window, a diamond-shaped window, right? So that's what we call a Chambrot window, which is normal in every healthy person. But with the clubbing, what happened, as it get into the drumstick or the spoon shape, we don't see that window there, or in other words, they have negative Chambrot windows. What we want is a positive Chambrot window. As you can see, yes, so with the normal, the window is evident. With the clubbing, that window is not there. And the next classic finding we see with the Tetralogy of Fallot, these children, they may exhibit squatting position, as you can see right here in this image. So what is happening here? I mean, in this posture, what you can see, blood flow to the extremities is limited. So that means you're going to supply more oxygenated blood to the vital organs. So by reducing blood flow to the extremities, blood flow to the vital organs increase. So it's another adaptation process how they can overcome the crisis when it develops. The next classic finding you can see in the list is harsh systolic murmur, and I believe everyone know what murmur is. And as you can see, by definition, is unusual heart sound, because of forceful blood flow from one chamber to other, or from one blood vessel to the other. I mean, here we know there is a strong blood flow from left ventricle to the right. Yeah, so that's what is causing the cerebri murmur in this case. And again, what we call here, it as the harsh systolic murmur, which is very specific for TOF. So another classic finding we may see in these children is collateral circulation. And what is collateral circulation? I mean, some of these terms could be so classic on NCLEX if you have noticed. So there are several different conditions which can cause collateral circulation, and this is just one of them. Basically, it is another compensatory mechanism of the body. So when there is a decreased blood flow through a vein or artery, there is a compensatory mechanism which allows more blood to flow in that region, and that's what we call as collateral circulation. And again, it could be with arterial or venous conditions. So just think about a couple examples other than TOF. So take the case of a patient undergoing open heart procedure. So for graft purpose, they may take a blood vessel from the arm or from the leg. What happens at the site where we take this blood out, there will be formation of parallel vessels, what we call collateral circulation. The same applies when a patient undergoes venous ligation for varicose veins. So again, it could be several different conditions which can cause collateral circulation, which is nothing but parallel circulation, as you can see here in this image. Okay, and here comes the last but probably the most important complication that they may test in relation to TOF, what we call TET spells or cyanotic spells. So let's try to understand, I mean, the TET stands for Tetralogy of Fallot, the TET spells or cyanotic spells. As the name suggests, they can have significant cyanosis when this happens. So how does this happen? So this may occur anytime. So as you can see here in this image, what TET spells is an exacerbation of the cyanosis, which can happen during crying or feeding or while we take care of the child. So the peripheral tissue and the perioral tissue can turn really cyanotic or bluish. So that's what TET spells is. And again, as I told you, this is an exacerbation of the tetralogy symptoms itself. And what can they present in this situation? They can have severe cyanosis, then tachypnea, like increase in the respiratory rate, flaccidity, where the body can go into a state of lack of muscle tone, and then tachycardia, increase in the heart rate, and then altered level of consciousness. And this may even advance into seizure, severe, or death. You can imagine it's a real crisis we had to deal with while we take care of these patients. And then how do we manage TET spells if that happens? So we have immediately put them into Nietzsche's position. Again, this has the same application. Remember we were talking earlier with the squatting position, the same effect. What we heard with the squatting, the blood flow to the peripheral tissue decrease and blood flow to the vital organs increase. The same way, when we put them on Nietzsche's, we are trying to improve the blood flow to the vital organs. And how do we actually achieve that? So we really cannot put a baby in Nietzsche's position as such, but you can see this image shows. So simply flexing the legs and the arms to the body can achieve the same goal. It can reduce the blood flow to the extremities and provide more blood to the vital organs. So that's how the Nietzsche's position will help here. So another treatment option is morphine, which also can reduce oxygen consumption and help them overcome the crisis. And then you also see propranolol as one of the treatment options. It's a beta blocker. It helps to reduce the heart rate. And finally, prostaglandins, that could be of real help in this situation. And this is another important information. I'm going to come up with another video as a comparison, something you must know, the difference between prostaglandin and prostaglandin inhibitors. So just for a quick preview, whenever we talk about prostaglandin inhibitors, they are nothing but NSAIDs, the non-steroidal anti-inflammatory drugs like aspirin or ibuprofen or indomethacin. Those are the prostaglandin inhibitors, which are nothing but NSAIDs. And prostaglandins are chemicals that our body produces, which has pretty much the opposite effect of prostaglandin inhibitor. Again, we're going to come into the specific comparison in another video. And how does it help here? Prostaglandins can help to open up the pulmonary valve and help more blood flow into the lungs. So thereby, there will be better exchange of gases with improved oxygen concentration. So that's how prostaglandins, again, they will open up the pulmonary valve, allow more blood to get into the lungs and better exchange. And whereas prostaglandin inhibitors, they are vasoconstrictors. By the way, another important point to mention here, prostaglandin inhibitors like indomethacin is a classic drug of choice we used to treat PDA. Remember, we're talking patent ductus arteriosus in another video. Yes. So to treat that, we use prostaglandin inhibitors because they are vasoconstrictors, whereas prostaglandins are vasodilators. And other than the general management we're talking so far, let's also look into the surgical management for TOF, and which is categorized into palliative procedure and corrective procedures. And under the palliative, as you can see, a particular procedure called a BT shunt comes, whereas corrective surgery is a total repair of all the component defects. Remember, we're talking about the 4 component defects. They all will be corrected here, and so that's what the corrective surgery is. But let's talk a little bit more about the palliative correction here, which we again see in questions, the condition, a procedure what we call as BT shunt. To understand BT shunt, let's have a quick recollection of the anatomy of the arch of aorta and the related structures. Okay. So as you can see here in this image right here, so you can see, okay, that's our aorta, yeah, the ascending aorta, then the arch of aorta, and then the descending aorta. And you can see there are three major vessels arising from the arch of aorta. You can see the one on the right, that is brachiocephalic artery, and then you see the left common carotid artery, and then you see the left subclavian artery. And also you can see the first one, which is the brachiocephalic, that split into form two vessels which are actually corresponding to the other two on the left. So that is the right subclavian artery and the right common carotid artery. So all together you can see there is right subclavian artery which goes to the right arm, then there is right common carotid artery going to the brain, then there is left common carotid artery going to the left side of the brain, and the left subclavian going to the left arm. So those are the four vessels which are arising from the arch of aorta. So now coming to B tissue, what do we do here? So first of all, understand what happened with the TOF. We heard the problem is not that they have a lot of defects. Rather, the main problem, the pulmonary valve is stenosis. The pulmonary artery valve is stenosis. So when the pulmonary valve is stenosis, what happened? Blood from the right ventricle cannot go into the lungs. Unless the blood flows to the lungs, how does it get oxygenated? So that's why their oxygen level in the body is going to go down. So here in B tissue, what we do, we try to make an artificial connection either from the right subclavian to the right pulmonary artery, or the left subclavian to the left pulmonary artery, as I'm going to show you right here in this image. So once more, either the right pulmonary artery is connected to the right subclavian, or the left pulmonary artery is connected to the left subclavian. And how does it help? Remember once more, the problem here is blood cannot really go into the lungs and get oxygenated. So here we are redirecting the aortic blood back into the pulmonary circulation so that it gets a second chance for getting oxygenation. And once that blood returns back to the left atrium and then it gets pumped out, the overall oxygen concentration in the body will improve and they can be relieved of the symptoms. So again, this is a palliative procedure, not a correction, not a permanent solution. So temporarily they can overcome the symptoms and can function better. So that's the purpose of this Blalock-Tosic shunt. Again, once more, is a connection between the right or left pulmonary artery with the right or left subclavian vein. So that way the aortic blood gets a second chance for getting oxygenation, the overall oxygen level in the body improves, and the cyanotic symptoms will decrease. And that will finish the lesson on Tetralogy of Fallot. I hope it was helpful for you to understand the concepts properly, and now you may be able to apply that effectively in the questions you're going to come across. So please do come back and watch many other important videos from DiCarmel NCLEX Review. Thank you.